Welcome. I don't know if we need a couple minutes to, if you feel like you need to stretch or, move around a little bit. I know it's hard sitting still for a long period of time, so feel free to move around a little bit or anything if you need to. And again, my name is Carolyn Crumley, and I'm going to talk a little bit about skin, show me how to keep it intact. So I welcome everyone to the Missouri Show Me State. If you didn't know that, we are called the Show Me State, so that means you can't just tell us stuff, you have to show us. So I'm hoping to show you a little bit about how we manage keep the skin intact and then manage skin conditions. And I currently live in Kansas City, but I actually am from St. Louis. I grew up here and have family here. So hopefully you'll enjoy our city and have a chance to, if you are able to eat some Emo's Pizza and some Ted Drew's frozen custard while you're here. So I have no financial disclosures. I have the learning objectives there. We'll talk a little bit just about the what the skin looks like and how it functions, what some of the issues are related to skin, and then hopefully how to resolve some of those. And I think we'll get through this fairly quickly, so I should have time at the end for any questions. And then I believe also there's a round table or some kind of a session over in the exhibit hall where some of the speakers are available if you have individual questions, so I'll be in there also. So I work at St. Luke's East Hospital in Lee Summit, which is a suburb of Kansas City. And of course, Kansas City is known for Go Chiefs, Super Bowl champs. And then I also am an adjunct faculty at the University of Missouri-Columbia, and I am a section editor for our journal, the Journal of Wound Ostomy and Continence Nursing. And both individually and on the local level and the national level, I am very involved with the Wound Ostomy and Continence Nurses Society, which is more of a professional organization for providers. But then we also work closely with a couple of the patient advocacy groups that are associated with our practice, including the United Ostomy Association of America, who works with patients with ostomies, and also the Friends of Ostomies Worldwide, which is an organization which collects ostomy supplies that are no longer needed by the patient. Maybe they changed the type of pouch they're using, or they've had their ostomy reversed, and they collect those and send those to third world countries where they really don't have access to supplies. So we support them with donations of financial donations and also with sending them supplies to help out those patients. So a little bit about the skin. You can see kind of a depiction there. Of course, we can't really see this on a visual level because the skin is really very, very super thin. And it varies a little bit. It's the thinnest in your eyelids. It's a little bit thicker on like the palms of your hand and the soles of your feet. But still, it's very, very thin. Not anything that we're going to be able to see these features except with a microscope. And so, I'm going to move over here a little bit so I can see this one a little bit better. So you do have the hypodermis, which is the inner layer, which is where you have all of your blood supplies, so your arteries and veins. It's also where you store your adipose tissue or your fat tissue. Some of us have more of that than others in various parts of the body, but that does serve a purpose. And then in the dermis, where you still have blood supply to that, is where you have some of the skin appendages. And so this would be like the hair follicles and the sweat glands and the sebaceous glands, which we'll talk about a little bit more as we talk about some of the skin issues. And then the outer layer is the epidermis. And so it has several little layers, again, if you looked under a microscope. And what happens is the bottom layers of the epidermis make new skin cells on a regular basis. So about every 14 days or so, those skin cells that are formed at the surface kind of migrate up, and then as they migrate up the levels, the nucleus dies and they sort of die off, and then they flake off. Now, this is all microscopic, so it's not really anything that we see. We don't see the skin coming off. Most of it is when you're either like showering or bathing or even putting on clothes where you kind of brush some of it off. But if you go around your house and dust with your little swipper or your dust rag and you see all that dust, a majority of that is skin cells that we just don't see. And that becomes important because sometimes that natural process gets interrupted and we see skin problems with a patient who maybe has had a dressing for a long time, or just that area is not getting cleansed, or there's not anything to brush the skin off, so it can build up a little bit and create a problem. So the skin is, although it's the largest organ in the body, a lot of times we feel like, it gets pushed aside from all of the other organ systems, which naturally, cardiac and pulmonary things come first, GI things, but a lot of times the skin is an afterthought until we start having problems with it. And I think a lot of people don't really understand what the various functions of the skin are and why it's so important to keep it functioning properly and keeping it intact. So one of the things that it does is thermoregulation. So it regulates our internal body temperature. First of all, like I mentioned, we have those fat cells that are in the hypodermis that provide really good insulation to the insides of our body. But then also the blood vessels in the skin can either vasodilate, meaning expand, or constrict, meaning narrowing down, to help your body get rid of extra heat or conserve that heat if you need it. So it really serves an important function throughout the body. Again, with that insulation goes along with it. As far as immunity, of course, we know that intact skin is a barrier to any kind of organisms entering the skin. And even when you can have like a small little cut, we've seen people even with like a little paper cut on their finger, that if you get the right bacteria in the right circumstances, that can set up an infection because now the bacteria has found a way to get into the skin. But even aside from that, the skin also produces various substances that help our immune system to fight off infection. Sensory perception, of course, is where we get our sense of temperature and pain and touch, and also itching. We kind of talked about the barrier protection. Along with that, too, our skin, and this will be important because we'll talk about this in a few minutes. Our skin, the natural pH of our skin is on the acid side. So if you remember from your science classes in high school, there's pH, and 7 is like right in the middle where it's not acid and it's not base or alkaline. And so our skin tends to be a little bit on the acid side. So it has a little bit lower pH, like anywhere from 4 to 6.5. So a little bit less than neutral. And that's important because that also plays an important function in, again, maintaining all of these activities of the skin and reducing the risk of bacteria creating a problem. And then lastly, the skin serves a purpose as far as vitamin D synthesis. So we know that you need to get a little bit of sunlight. That's what helps your body synthesize vitamin D. Takes a combination of some sunlight and in the skin, that's what we use to come up with the vitamin D that we need for our functioning. And if you have low levels of vitamin D, you can have issues. Of course, what we normally think about is like bone loss, because if you're low in vitamin D, you don't maintain your bone integrity as well. But they're also finding more that it does have a role in our immune system and keeping it functioning, and also actually even preventing some types of cancer. So again, that's where the skin plays an important role. Okay, so it helps to have that little bit of a foundation about how the skin works in order to talk about some of the ways that we can just normally keep it intact, and then also address some of those issues that we sometimes see where the skin is not intact. So it is important, again, because of that acid mantle, that we want to use products that are pH balanced. And of course, we see that on a lot of advertisements. This is pH balanced on soaps and shampoos and lotions and creams and everything, but we'll talk a little bit more about what that means. We also want to make sure that you're avoiding really hot water or overly cleansing, because that can also affect the skin integrity. especially as we get older, as we're younger, we kind of get used to taking a bath or a shower every day. But as you get older, you really a lot of times don't need to bathe completely that frequently. Some people do every other day, or especially like a lot of individuals that are in nursing homes, they only bathe them a couple times a week. They may kind of wash their face and do some pericare, private areas, but you don't need a full bath and shower, because a lot of times then you're just drying out the skin, and again, that can lead to some issues. And then it is important, it's kind of just common sense and I think practice, but it is important if you are going to use any moisturizers, it's really best to put those on right after you bathe, right after you get out of the shower or bath, because it helps trap that moisture a little bit more and keeps the skin intact. So there are, tons and tons of skincare products on the market. We have certain ones that we use in the hospital because I do work primarily in the hospital and seeing patients, so we have what we have on formulary. But if you go into, your local discount store or drugstore, you can find a million different skincare products. And it's really hard. People always ask me, well, what's the best one? Well, I think everybody sort of has their favorites. But you do need to understand what the ingredients are, and sometimes when you understand that, you can look a little bit more closely at the ingredient label and see what's in there, and what are the more active ingredients in there. So most of the different skincare products are broken down into humectants or emollients. So humectants actually actively attract water into the skin. And so that's things like urea, lactic acid, glycerin, and the alpha hydroxy acids. Most of those are over the counter. There are a few of those, especially containing the urea, that are prescription, that may need to be prescribed by your primary care provider or by a dermatologist. Lachydrin is one of those that we use in the hospital that has like a 12% urea, but it does require a prescription. So those help really pull that fluid into your skin. The emollients are more for like softening and moisturizing and sort of keeping, once you have that moisture in the skin, keeping the moisture in. And some of the main ingredients of that are going to be silicone, dimethicone, lanolin, and then one of the newer ingredients is the ceramides. That's kind of a hot topic both in the cosmetic skincare industry and then also within healthcare. We now use some products that have ceramides because they know that that can help maintain the normal skin integrity. So the common one on the market is CeraVe. They have a lot of different ones that have ceramides in it. So again, as we talked about earlier, as far as the pH of soaps, now this is not something that you're going to see regularly if you pick up a bar of soap or a bottle of some kind of a liquid cleanser. They don't generally say on there what the pH is. Again, there's really no guidelines for them calling it pH balance. They can kind of put that on there regardless. But there are several websites that you can go to. This was a particular one that I found. If you Google it, you can find, if you just Google pH of soaps, you can find all these. And this was just a partial list. It was from this particular website that I had found that listed several of the common skin cleansers. And they go in order of the lower pH. And as you can see, some of them, that we use pretty regularly, like Zest soap has a pH of 10. So again, if we want to keep it on that 7 or under, we want to try to avoid those ones that have the higher pH. Even Johnson's baby soap, which is supposed to be good for babies, but it's got a really high pH. So if you're curious about what you normally use or want to try to get into something that has a lower pH, again, there are multiple websites that will list the pH for you. Okay. So that's kind of just an overview of normal skin and how we maintain it under normal circumstances. And so now I'm going to talk a little bit about some of the issues related to individuals that do have various ostomies that it could, and we see common problems around the skin, and then we'll talk a little bit about what some of those problems are and how they can be dealt with. So again, I'm a wound, ostomy, and continence nurse. So as the name implies, we deal with patients with wounds, with various ostomies, and with continence, bowel and bladder control issues. But our specialty originated as ostomy nurses. So we used to be, years ago, when I'm old enough that even back when I went through the education and the certification, we were called enteral stomal therapists. So you sometimes still hear us referred to as ETs, and in some other parts of the world, they're still called ETs. And so we work a lot with patients who have had either a colostomy, ileostomy, or a urostomy. So we'll talk a little bit about those. A colostomy or an ileostomy is a diversion in their GI tract involving stool. Urostomy, I really didn't talk about too much because it's less common, although some of the principles would apply. Those are a patient who's had their bladder removed, and so their urine drains through an opening on their abdomen. So our specialty really probably deals with those more, but through the years we have also sort of picked up what we call other tubes and devices, like gastrostomy tubes and jejunostomy tubes that may be used, especially initially in the hospital. Sometimes gastrostomy tubes are actually used to decompress the GI tract or to pull fluid out, but then eventually used for feeding. So we'll talk about those a little bit. Just in general, and then some of the skin conditions involved. So here's just a picture of your GI tract. I'm sure you are all very familiar, but this is where we start with our new ostomy patients, just explaining a little bit about how the GI tract works, because then it starts making more sense to them in relation to the type of ostomy that they have. So as you're familiar, if you are taking orally, you ingest the food, it goes into your stomach. There it starts to mix with some digestive enzymes, and some of the acid in the stomach starts to break down some of the nutrients. Especially it's important for breaking down the vitamin B12. There's also some intrinsic factor that's released in the stomach that has to do with B12 absorption, talked about a little bit in the previous session. So the food kind of starts to break down, mix with some of those digestive enzymes, and then it goes all through the small intestine, which is sort of all over the middle of your belly. It's the longest part of the intestine, and that's where you absorb most of your nutrients. So your proteins, fats, carbohydrates, vitamins, minerals, most medications. There's a few that are absorbed in the stomach, but most medications get absorbed in the small intestine. It's still pretty watery at that point, and that's important for patients that have one of these ostomies as far as the consistency of their stool. Then from the small intestine, it enters the colon, or the large intestine, on the right-hand side, which is a little more fixed, comes up the right-hand side, goes across sort of the top of your belly, down the left-hand side, down to the rectum and anus. So the main function of the colon is to absorb water. So the more, when it starts out in the colon, it's pretty watery. The farther along it goes in the colon, the more water gets absorbed. So then you have the formed stool, and your rectum and anus give you the voluntary control. Then we'll talk a little bit about some of the different ostomies and what that means in relation to what it means for their digestive system. Because again, they get all kinds of weird misconceptions about, what's going on with their, that they can't eat certain things, or they're going to have to, do all kinds of different things that are misconceptions. So we also, along with that too, some patients, again, have a gastrostomy tube, or it's sometimes called for short a G-tube, or a PEG, which is a percutaneous endoscopic gastrostomy. And these are tubes that are inserted into the stomach. And again, they may initially be to drain, to decompress the stomach, but then often used for feeding. Again, we don't, as WOC nurses, we don't get very involved with the nutritional aspects of it, because we deal with our dietitians and our nutrition teams, or our GI doctors, as far as prescribing the type of nutrition that goes through the tube. But where we get called a lot is because then the patient has developed some irritation around the tube. And I have a few pictures. I don't have as many for the gastrostomy tubes because we don't see them as much. But a lot of times when we do get consulted, invariably it's because they have an infection or cellulitis, because there's some redness around the tube. And in reality, what it is more, and we'll talk about some of the moisture-associated skin damage, but really in reality, it's more that something is leaking around the tube, most often because it hasn't been stabilized well, And if the tube is not stabilized, the more it wiggles around, the more it makes the hole bigger, and the more things tend to leak around it. So a lot of it is just stabilizing the tube and minimizing the leakage, and then some of the basic principles as far as managing the skin irritation. Very rarely do we actually see true infections or true cellulitis. It's possible, but most of the time, whoever put in the consult just saw that it was red and assumed that it's infected. Jejunostomy tubes then would be farther down into the small intestine. For some reason, maybe needed to bypass the stomach because of issues. So these would be generally feeding tubes that are inserted into the jejunal part of the small intestine. We don't tend to see quite as much leakage with these. They're a little bit smaller tubes, and at least in my practice, we don't see them as much in the hospital. But same principle, we can sometimes see some of the issues with irritation around the tubes. Far more often we see issues with our ostomy patients. So a patient who has had a colostomy could have a diversion anywhere along their colon. So it could be on the right side, the ascending colon, anywhere in the transverse colon up across the top. Generally, they try to do them in the descending or the sigmoid colon. So the farther down, so we've not bypassed as much of the colon. So really, those patients, if it's a low descending or sigmoid colostomy, it really hasn't affected their ability to their nutrition or their ability to absorb nutrients at all. Really, the only thing they've lost is that voluntary control of the rectum to expel the stool. So these patients tend to do a lot better, both from that standpoint, because it hasn't affected their nutrition and absorption, and also the stool is more formed because it has had a chance to go through the colon. So formed stool coming out, even if it leaks on the skin, is not as irritating. We try to explain it's just like if you have a baby and they go around, they'll walk around all day with a diaper on with formed stool in it and not have any issue. But then when they have diarrhea, then that's when they get like the diaper rash or the diaper dermatitis. So these patients tend to do a little bit better and not have quite as many issues. Patients that need to have an ileostomy, again, now we've basically bypassed the colon. The food is not going through the colon, so they have sometimes some more issues with nutritional deficiencies, with dehydration, with not absorbing as well. Also, the stool is a little bit more loose, so there tends to be more issues with it leaking or causing issues on the skin, can be a little bit more problematic to manage. And then patients who have these ostomies use various types of devices. There's literally hundreds of them on the market. I've seen lots of changes since I started in this, 40-something years ago. A lot of the products now are really much more skin-friendly and easy to use. And again, there's various companies that make all kinds of variations, but they're usually a variation of one type or the other. So it's either a one-piece pouch where you have the skin barrier and the pouch connected, so it's just everything goes on together, comes off together. The barrier is cut to the size of the ostomy, and then it adheres to the skin. So they're all adhesive. There are a few non-adhesive options for patients who really have issues with their skin or with the adhesives. Most people prefer to use the two-piece, and there's a lot of different two-piece. So that's where the barrier adheres to the skin, and then the pouch either snaps on by some kind of a device, kind of like a Tupperware seal, or some of them are adhesive, where it's just adhesives that connect the pouch and the barrier together. And that's part of what we do then, is teaching the patients how to manage it, helping them problem solve if they have special needs for their ostomy. Okay, so now, again, if everything works perfectly, these patients have these G-tubes or J-tubes or ostomies and not have any issues, but unfortunately we do see a lot of different issues associated with it, and they fall into the category, the general category that was developed over the term that's kind of come into place over probably the last 10 years of moisture-associated skin damage, or we call it MASD. So there's basically 4 forms of MASD. There's incontinence-associated dermatitis. So that's somebody who either has bowel or bladder incontinence and have some issues on their perineal skin or their buttock skin because of that moisture. Intertriginous dermatitis, which really can happen in any population, is more with the skin fold. So people have a skin fold somewhere and the moisture gets trapped, and we'll talk about that a little bit. And then there's peri-wound moisture-associated skin damage from some sort of drainage from the wound, moisture from any source. And then peristomal moisture-associated skin damage, which generally we think of more with the ileostomies and colostomies, but really could also apply to the gastrostomies and jejunostomies if they're having any kind of skin issues. So what happens with this, again, you have moisture from some source. It could be either perspiration that gets trapped, it could be urine, stool, saliva, wound drainage, leakage around a tube, whatever is causing the extra fluid to be contained. You get increased skin permeability, so that moisture, skin doesn't like being, it needs to be a little bit moist, but it doesn't like to be that moist. So then there's kind of increased permeability, and then that's where the pathogens can get in. So you can have more of the bacteria and the harmful components getting into the skin. And then also the skin is much more at risk for the dangers from friction or shearing or pressure. So again, somebody that has incontinence-associated dermatitis, where they have a lot of moisture, it's going to put them at a greater risk of having a coccyx or a tailbone pressure injury, because that moisture just makes them that much more at risk. So we want to try to do what we can to try to address that excessive moisture. So here's some pictures of some moisture-associated skin damage. Over on the far right, that's a fairly mild case that we see around a perianal area from some irritation. The upper one in the middle is pretty extensive moisture-associated skin damage. A lot of times people will think that's like a pressure injury or something else going on, but it's really just the effects of prolonged moisture. You can sometimes see it around a tube. I'm not sure if that's a G tube or a J tube on the bottom in the middle. And then this one on the far left actually was just a patient that I saw a few weeks ago. We got called down to the ER, and he was actually sent home with a drain. He'd had some laparoscopic surgery and had a drainage tube that sometimes patients will have after surgery to pull the excess fluid out. And he was sent home with it with a kind of an occlusive dressing on, so like some gauze and some Tegaderm over it. Tegaderm was like that clear adhesive. And he had been home for about a week, and it had started leaking a little bit around the tube, and nobody had instructed him to change the dressing, and it, I guess, didn't occur to him. So all that moisture was just leaking around there. You can kind of see the gauze that's folded back. So again, we got consulted for cellulitis, which means a bacterial infection of the skin. It's like, there's no infection here. It's just from all that moisture being trapped on his skin. So as soon as I took that dressing off and cleaned it off really well and put a moisture barrier on there and then put a dressing back on, I mean, it healed up very quickly, which then makes us look really good, but it was a pretty simple fix. It's like, let's just get the moisture off. Now, this probably doesn't mean a whole lot to you as far as ICD-10 coding for moisture-associated skin damage, but this is something that our organization, Wound Ostomy and Continence Nurses Society, has lobbied for many years to have these codes recognized, and developing the specific codes for moisture-associated skin damage that they put under the category of irritant contact dermatitis, as opposed to like allergic dermatitis or radiation dermatitis. And the reason this is so important is that healthcare providers live and die by ICD-10 codes, because if there's not a code for it, you can't bill for it. So then it's hard to get people to want to take care of these patients because they really can't hardly bill anything for it. So this was really important in advancing the care of patients that have these type of issues, so that providers are more willing to see these patients, work with these patients, because they can get reimbursed. So it was a really big step that we've spent many years accomplishing. So that was a big a big accomplishment. Okay, so prevention and treatment of moisture-associated skin damage. The obvious answer is just try to avoid the excessive drainage. So again, if it's a tube that the opening has gotten enlarged, then try to stabilize it so it doesn't leak around it. Rare cases, sometimes they have to move the tube to somewhere else, but most of the time we can get it stabilized and get that under control. If it's an ostomy, then we need to make sure that we have a pouching system that is not leaking as much and try to find some way to manage that. Or if it's really liquid stool, sometimes we work on trying to thicken up the stool, because if it's thicker, it's less likely to leak. If it's incontinence, then we want to work with them. There are a lot of ways that you can improve continence. Unfortunately, a lot of people think that as you get older, it's just a normal part of aging and you just have to accept it, but there are a whole lot of different treatments, pharmacologic, non-pharmacologic, behavioral, that can improve bladder and bowel control. But again, a lot of times people don't seek help, and that is part of our specialty too, is working to do that. If we can't improve their incontinence, then ways to manage the moisture. If they're incontinent, maybe like for a man, an external catheter or a condom catheter to a bedside drainage bag. We want to try to avoid any of the catheters or internal devices because of the risk of infection, but there are a lot of different external containment devices. Or if they are going to have to use a containment product, something that really wicks the moisture away better, like the new baby diaper technology that wicks it away. Sometimes in like facilities or even patients buying their own, they buy kind of the cheaper products and it doesn't have that really good technology that helps keep it dry. So that's the first thing we want to do, is try to figure out how can we contain the drainage. And then we want to protect the skin. So there's a lot of different options for that. And first of all, we want to make sure that we cleanse the skin well. Sometimes it's better to not use a lot of harsh soaps, and particularly with our ostomy patients, we teach them to not use a lot of soaps and lotions and creams, because that interferes with that adhesive barrier sticking. But also it can irritate the skin. And whether it's around a tube also, a lot of times people want to use a lot of really harsh cleansers that just irritates it more. And people love peroxide, right? Everybody loves peroxide. Don't you need to clean it with some peroxide? Well, peroxide has is really harmful to healthy skin. And people think that it has antibacterial properties. It really has none. It fizzes and it bubbles and it makes you feel like you're getting it clean. It is good if you have like a lot of like dried blood, like somebody who's cut their head and they got a lot of dried blood in their hair, or dried drainage or blood. It kind of loosens that up, but it really doesn't have any antibacterial properties, and it actually destroys good cells. So we want to just cleanse with regular plain water, maybe a mild soap, and rinse it off well. We have different options and we kind of go in order. Sometimes you just need like a dimethicone based. Some of those are just more of the lotiony type materials that have some dimethicone that provides some protection. If you just need a little bit, sometimes that's enough. Then the next step, I should have kind of put these more in order, but the next step would be like a petrolatum or a Vaseline based that provides some moisture barrier protection. And then if that doesn't work, then we go up to the zinc based. Familiar with Desitin, what we use for baby bottoms. There's a lot more. I mean, years ago when my kids were little, all there was Desitin. Now there's butt paste and some kind of goo and all kinds of different things that they have, but it's basically all Desitin, zinc-based options. The only problem with the zinc-based is it's pretty thick, so it's sometimes kind of hard to remove. The key with it, if you really have bad breakdown, is to put it on thick, whether it's on a bottom, an adult bottom, a baby bottom, a rounded tube. Clean it off good, put it on very thick, and then you don't necessarily have to, each time you wipe it all the way down to skin. You can kind of wipe off the outer layer, wipe off the urine or stool, and then put more on. And then maybe once a day or every other day, clean it all the way down to the skin. But we get patients that get raw from people trying to scrub the zinc-based products off. And then there are some liquid acrylates, which is kind of a newer category. They're like the skin preps. They sometimes come in like the little pledgets, but you can also get wands, and there's some really advanced ones on the market now that provide almost like a protective coating that sometimes lasts even up to 72 hours to protect the skin. So we'll just kind of go through these pretty quickly because I know we're running short on time. So intertrigo, again, is that what we talked about where you get the moisture trapped in the skin folds. We most often think of it in like the if somebody has a large belly and kind of under their belly and in their groin folds. We can also get it under breast, in axilla. And the main thing is just keeping it clean and dry and trying to wick away the moisture. So here's some examples of that. It's usually, we kind of call it a kissing lesion, where you see the same thing on either side in the skin fold. Usually the deepest damage is in the depth of the skin fold where the moisture is trapped. And the main thing is just keeping it clean and dry, keeping the skin separated. Years ago, we just, in the hospital, all we had was pillowcases. When I did home health, we'd teach patients to cut up cotton t-shirts and put it in there. Now we have several commercially available products. And I guess I'm allowed to say brand names. Interdry AG is one of the brands that we use, that it's a special fabric. It's like the wicking fabric in athletic wear, like the dry fit moisture wicking, and then also has silver in it. So it wicks the moisture out to the edge and lets it evaporate, so you don't have all the moisture in the skin fold. But it's good, like I say, sometimes even like around tubes, if we really want to wick the moisture away, we use it pretty creatively. Sometimes along with that excessive moisture, you can get fungal infections or candidiasis, which is like a yeast infection. The main way you can tell that is you see the little, what we call satellite lesions. So the little polka dots around the outside, which means that there's a fungal infection there. And so you do want to treat with that with some sort of an antifungal. There are ones over the counter. Miconazole powders and creams are available over the counter. Nystatin does require a prescription. There are some that also include steroids, which is kind of comforting and helps with some of the inflammation, but you do have to be really careful with not using that on a long-term basis because it can kind of thin the skin. You can also get folliculitis, which is an inflammation of the hair follicles. In the previous section, she kind of talked about some issues with the hair follicles, but this is actually where the hair follicles get inflamed, and it's usually either from shaving and then the hair growing back in, or something irritating it. So the best thing with that is to trim the hair rather than shaving it. If it's possible, to not use adhesive devices, or if you do, remove them carefully so you're not irritating it. Sometimes they do need some topical or systemic antibiotics to treat that. And I'll just go through this quickly. Another term is medical adhesive related skin injury, which is MARSI, where you can have problems with the skin strictly because of the adhesive. And it can be in a lot of different forms. Sometimes we can see it around a tube. If you see in that upper right, it's where somebody had kind of ripped the skin, taking off an adhesive pouch barrier. And then sometimes you see like the skin tears like that below, where it actually pulls back a flap of skin from the adhesive. So the main thing with that is, again, if it's possible to not use an adhesive option, gently remove it. When you do put it on, allowing it to dry really well, and then avoid using tincture of benzoin. A lot of people use that because it makes stuff stick, but sometimes it makes it stick too much. And then lastly, we don't really deal a whole lot with patients with central venous catheters, like for parenteral nutrition, but occasionally we do get called to see them because they have some redness. And typically what it is it's because when they did the care around the site, they didn't allow it to dry well and put the adhesive on it to trap moisture. But this was a recent study that was just in our journal last month, looking at some patients who had a central venous catheter. Now, these were more patients for cancer treatment, but they looked at a total of 1,172 patients, found that some of the risk factors for having issues were because they had a previous MARSI injury, they were on TPN, other catheter-related infections, a history of allergy, and a PIC. And they found that it was pretty common that per 1,000 device days, which is how we measure complications related to various tubes, there were 1.7 events. So mainly irritant contact dermatitis, again, the skin getting irritated, some mechanical skin injury, and then some skin tears. So that pretty much wraps it up. I included a few resources there for you that have more information on some of these topics. The UOAA site has a lot of webinars available. And I think we have just a couple minutes if there are any questions. Or if no general, oh, there's one over here. I was saying that if not, if there are no general questions, again, I'll be available.
So I just have a question about, I have had several PICC lines, and we use the sensitive skin dressing already, but we still have issues where my skin will kind of like look like it's like scaly almost when they take off the dressing. It's like real dry and itchy. So is there anything to do to kind of prevent that?
Like I say, probably the first thing that we always say is just making sure that, so when you take the dressing off and they use some sort of an antiseptic to cleanse the skin, just making sure that that really, really dries. And especially nurses are very impatient.
Yep.
They don't tend to wait, and we say like 2 to 3 minutes, like a real 2 to 3 minutes, not like, oh yeah, that was 2 to 3 minutes. Okay. Really letting it dry so that is not on there. Sometimes there are different types of dressings than what comes in the kits. Yep. And so sometimes you can, try a different dressing. Some of them have more moisture vapor. Oh. If not, then sometimes they have to go to alternative dressings, which is kind of a last resort because then you don't have occlusive. I mean, occasionally you have to go to like gauze and tape, but then it doesn't protect the site as well.
I'll just have to set my timer for 3
minutes. And just keep saying, nope, wait. Okay, well, thank you very much, and enjoy the rest of the conference.